Opioid use disorder represents one of the most devastating public health crises of our time, affecting millions of individuals and families across the globe while claiming hundreds of thousands of lives through overdose deaths. In the United States alone, more than 2.1 million people suffer from opioid use disorder, with the crisis touching every demographic, socioeconomic class, and geographic region. This epidemic has fundamentally altered the landscape of addiction medicine and highlighted the complex relationship between legitimate medical treatment for pain and the development of substance use disorders. What makes opioid use disorder particularly tragic is that many individuals first encounter these substances through legitimate medical prescriptions for acute or chronic pain, only to find themselves trapped in a cycle of dependence that can be extraordinarily difficult to break. The opioid crisis has evolved through several distinct phases, beginning with increased prescribing of prescription pain medications in the 1990s, followed by a surge in heroin use as prescription opioids became more difficult and expensive to obtain, and most recently dominated by synthetic opioids like fentanyl that are exponentially more potent and dangerous than traditional opioids. This evolution has created unprecedented challenges for healthcare systems, law enforcement, families, and communities struggling to address a crisis that continues to claim more than 70,000 lives annually in the United States alone. Understanding opioid use disorder is crucial not only for healthcare professionals but for society as a whole, as effective responses require comprehensive approaches that address both the medical and social dimensions of this complex condition. Neurobiological mechanisms and potency. Opioids exert their effects by binding to specific opioid receptors located throughout the brain, spinal cord, and other organs, mimicking the action of the body's natural endorphins and enkephalins. These substances primarily target mu-opioid receptors, which are densely concentrated in brain regions associated with pain perception, reward, and respiratory function. When opioids bind to these receptors, they produce powerful analgesic effects while simultaneously triggering massive releases of dopamine in the brain's reward circuit, creating intense feelings of euphoria and well-being that far exceed those produced by natural rewards. The potency of opioids in activating the brain's reward system is what makes them so uniquely addictive compared to other substances. While other drugs may increase dopamine levels by 2 to 3 times normal amounts, opioids can increase dopamine release by 10 times or more, creating an overwhelmingly powerful reinforcement signal that the brain interprets as essential for survival. This massive dopamine surge is accompanied by profound changes in brain chemistry and structure that begin with the very first use and intensify with repeated exposure. With continued opioid use, the brain undergoes rapid and dramatic neuroadaptation that fundamentally alters its normal functioning. The brain begins producing fewer natural endorphins and reduces the number and sensitivity of opioid receptors in an attempt to maintain balance. This process leads to tolerance, where increasingly larger doses are needed to achieve the same effects, and physical dependence, where the brain requires opioids to function normally. The neuroadaptation occurs much more rapidly with opioids than with other substances, with some individuals developing physical dependence within days or weeks of first use, even when taking medications exactly as prescribed by their physicians. Clinical presentation and diagnostic complexity. Opioid use disorder presents unique diagnostic challenges because the line between appropriate medical use and problematic use can be difficult to distinguish, particularly in individuals with legitimate pain conditions who may require long-term opioid therapy. The diagnostic criteria for opioid use disorder focus on patterns of use that cause clinically significant impairment or distress, including impaired control over opioid use, social impairment, risky use, and pharmacological criteria such as tolerance and withdrawal. However, the presence of tolerance and withdrawal alone does not necessarily indicate opioid use disorder, as these are normal physiological responses to regular opioid exposure that can occur even with appropriate medical use. The clinical presentation of opioid use disorder often involves a progression from prescription opioid use to increasingly problematic patterns of consumption. Individuals may begin by taking prescribed medications exactly as directed, but gradually find themselves taking larger doses or more frequent doses to achieve the same pain relief or pleasurable effects. This progression may involve seeking multiple prescriptions from different healthcare providers, a practice known as doctor shopping, or obtaining opioids through other means such as purchasing them illegally or taking medications prescribed to others. The transition from prescription opioids to illicit substances like heroin or fentanyl represents a particularly dangerous escalation that has become increasingly common as prescription opioids have become more difficult and expensive to obtain. This transition is often driven by practical considerations rather than a desire for a more intense high, as illicit opioids may be more readily available and less expensive than prescription medications. However, this shift dramatically increases the risk of overdose and death, as illicit opioids have unpredictable potency and are often contaminated with other dangerous substances, particularly fentanyl, which can be lethal even in microscopic amounts. Physical and psychological consequences. The physical health consequences of opioid use disorder are severe and multifaceted, affecting virtually every organ system in the body. The most immediate and devastating risk is respiratory depression, which occurs because opioids suppress the brain's respiratory center, leading to slowed or stopped breathing. This is the primary mechanism by which opioid overdoses cause death, and the risk is significantly increased when opioids are combined with other central nervous system depressants, such as alcohol or benzodiazepines. The introduction of fentanyl into the illicit drug supply has dramatically increased overdose risk, as fentanyl is approximately 50 to 100 times more potent than morphine and can cause fatal overdoses even in individuals with significant opioid tolerance. Chronic opioid use leads to numerous other physical health problems, including severe constipation that can result in bowel obstruction, hormonal disruptions that affect sexual function and reproductive health, and immune system suppression that increases susceptibility to infections. Individuals who inject opioids face additional risks including collapsed veins, abscesses, heart infections, and bloodborne diseases such as HIV and hepatitis B and C. The risk of infectious diseases is particularly concerning in the context of the opioid epidemic, with several communities experiencing outbreaks of HIV and hepatitis C directly linked to injection drug use. The psychological consequences of opioid use disorder are equally devastating and often persist long after physical withdrawal symptoms have resolved. Depression and anxiety are nearly universal among individuals with opioid use disorder, creating a complex relationship where opioids may initially provide relief from emotional distress, but ultimately exacerbate these conditions. The cycle of intoxication and withdrawal creates extreme emotional volatility, with individuals experiencing intense euphoria followed by periods of severe dysphoria, anxiety, and depression. Cognitive impairments associated with chronic opioid use include difficulties with attention, concentration, memory, and decision-making that can persist for months or even years into recovery. These cognitive effects, combined with the social and legal consequences of opioid use disorder, often result in significant impairment in work performance, educational achievement, and social relationships. The stigma associated with opioid use disorder further compounds these challenges, as individuals may face discrimination in healthcare settings, employment, and housing, creating additional barriers to recovery. Risk factors and epidemic patterns. The development of opioid use disorder involves a complex interplay of biological, psychological, and social risk factors, with genetic predisposition playing a significant role. Family history of substance use disorders increases the risk of developing opioid use disorder, with genetic factors accounting for approximately 40 to 60% of addiction vulnerability. However, unlike many other substance use disorders, opioid use disorder often develops in individuals with no prior history of substance abuse, highlighting the unique addictive potential of these medications. Medical factors that increase risk include chronic pain conditions, previous surgery or injury requiring opioid pain management, and certain medical procedures that involve opioid administration. Mental health conditions, particularly depression, anxiety disorders, and post-traumatic stress disorder, significantly increase the risk of developing opioid use disorder, as individuals may use these substances to self-medicate emotional distress. The co-occurrence of mental health conditions and chronic pain creates particularly high-risk scenarios, as these individuals may be more likely to receive opioid prescriptions and more vulnerable to developing problematic use patterns. Social and environmental factors have played crucial roles in the opioid epidemic, including aggressive marketing by pharmaceutical companies that downplayed addiction risks, changes in medical practice that emphasized pain as the fifth vital sign, and healthcare system pressures that led to increased opioid prescribing. Geographic factors have also influenced the epidemic, with certain regions experiencing disproportionately high rates of opioid use disorder due to factors such as economic distress, limited access to mental health services, and cultural attitudes toward pain management and prescription medication use. The evolution of the opioid epidemic has created new risk patterns, with fentanyl contamination of the illicit drug supply making any use of street drugs extremely dangerous, even for individuals who don't intentionally use opioids. This contamination has led to overdose deaths among users of cocaine, methamphetamine, and other substances who unknowingly consumed fentanyl-contaminated drugs, highlighting how the opioid crisis has created risks that extend far beyond traditional opioid users.